Hopkins, who's the Chief Executive of Worcestershire Acute Hospitals Trust, who's going to talk to us about the impact of the current wave of COVID-19 on hospital services. Thank you, Matthew.
Thank you. Morning, everybody. Thanks, Joe, for the introduction. Nice to see you all, although obviously not in person yet. I'm hoping in a few months' time we'll be in a position to do that. I'm hoping everybody can hear me okay?
Yeah.
Yes, very good. Okay. So I think the paper from our Trust Board meeting last week was circulated. If not, I'm sure it can be provided. It's in the public domain. That is based on some data that's now quite a bit out of date. The paper was written earlier in the month. So perhaps if I can give you some more up-to-date numbers to give you a sense of where things are from a hospital perspective at the moment. So on Tuesday was our highest number of new admissions into the hospitals of patients with COVID-19. So we had 52 new patients admitted on Tuesday, which is probably 20 to 25 more than our rolling 7-day average of admissions. We had 42 yesterday, so you can see that the numbers are continuing to increase in line with the rise in community rates that Worcestershire has been experiencing, perhaps over the course of this month. And the lag time for seeing admissions coming into the hospitals is generally 10 to 14 days after the rise in community cases. So we believe that we've probably got another week or two of those kind of numbers, 40 to 50 new admissions coming into the hospitals. Helpfully, though, we are discharging many people home again after they've come in with a COVID admission. For example, yesterday, as an example, we discharged 27 patients that had a COVID admission. And so it's not all doom and gloom, if you like, although the number of deaths now of people that had been admitted into the hospital over the course of the pandemic, really from last March, has now risen above 600, sadly. So we have discharged a lot of people home, but sadly 600 people have lost their lives as a consequence of the COVID infection through the hospitals. As of this morning, we had 265 inpatients that are positive, and we're now seeing probably around 40 to 42% of our overall beds across the 3 hospital sites, but predominantly at the Worcestershire Royal and the Alex site, that are either full of patients that have got COVID confirmed, those that are suspected, or those that are essentially recovering and likely to be discharged home. So the consequence of that has been quite significant. I'll talk first of all about intensive care. So colleagues may know that our 2 hospitals would normally have across the 2 of them a maximum of 13 intensive care beds at full level 3. We currently have 30 patients in our intensive care units across the hospitals. Breaking that down, we've as of this morning had 20 on the Worcestershire Royal site and 10 on the Alexandra site. And we've had to expand, as you can imagine, our intensive care facilities. So we've expanded out of the 2 main intensive care units on each of the hospital sites into our surge plan areas to make sure that we've got capacity to look after the most sickest patients that are being admitted. And of the 30 inpatients this morning in our intensive care units, 28 of them were COVID patients. And that balance has shifted quite a lot over the last 2 weeks, again, as a consequence of the rising cases in the county, in the community. To be able to do that, we've had to increase our staffing, because the rate limiting factor, predominantly the primary rate limiting factor is staff that are able, particularly nursing staff, but therapy staff and medical staff that are able to look after intensive care patients. And normally we would have a 1-to-1 ratio, one nurse to one patient, and we've moved from 1-to-1 to 1.8 patients per nurse, in line with the national guidance, which was expected, where we were expected to increase our capacity and therefore to flex our nursing staffing in order to accommodate extra patients. And we have a plan to move further out, if you like, if we need to 2 patients per nurse. And obviously we're reluctant to do that, but that's a case of necessity should we need to move from 30 patients, which we currently have, to our next, if you like, next maximum level, which would be 36. We have the outline of a plan to be able to increase our intensive care capacity to 40 beds, and we're hoping that we won't need to do that. But that's the plans that we have in place to accommodate any extra surge in demand really over the next week or 10 days. As I said, we're expecting things to continue to be difficult for at least that period. And to be able to manage that increase in patients needing intensive care, we've redeployed 109 staff from other parts of the organisation to increase the number of nurses and therapists on the intensive care units, and our anaesthetists, who would normally be anaesthetising planned operations, have also been moved onto a rota to support the intensive care rotas. So like many hospitals across the country, intensive care pressures have been a prominent part of our capacity and demand planning over the last month or so. Just to talk a little bit more about some of the other pressure points, we've also had an increase in the number of patients that are requiring support for breathing, but not full intensive care support. And our respiratory teams on both the Alex and the Worcestershire Royal site have worked really very hard to make sure that we're able to support the non-invasive oxygen therapy that those patients are requiring. And again, we've redeployed a number of other staff to support our respiratory wards. In terms of the overall staffing picture, we've got, as of today, about 530 staff that are off sick or absent from work as a consequence of either having acquired COVID in the community, a small number that will have acquired it at work, although we have very few outbreaks now at all across either of our hospital sites. And we've also got quite a number of people that have been asked to isolate through track and trace, and also through the lateral flow testing processes that we now have in place for staff and patients. And clearly, we want those members of staff to stay at home for the full isolation period before coming back to work. So the staffing pressures are both being caused by the extra capacity that we've got to put in place in respiratory and intensive care, but also the consequence of people having to be absent and self-isolating at home from work. In terms of then the wider impact on the hospital, I think the first thing to note is that really up until the second week of December, we were seeing pretty good waiting times for emergency care patients. And really since the middle of December through to the end of last week, we started to see some increasing delays in ambulance handover times as a consequence of the higher volumes of patients that were coming in. And what we've noticed this time compared to March, April last year is that the numbers of patients that are coming in with heart attacks and strokes and other emergency problems by ambulance has broadly stayed around the same levels. We've had slightly fewer people walking into our EDs at the Alex and at the Worcestershire Royal, but the number of ambulance dispositions have continued to be broadly what we would expect at this time of year, which means that in some ways that's a good thing, because people are ringing 111 and ringing the ambulance service when they're really sick, whereas I think were concerned first time around that people were keeping well away from hospitals, even though they really ought to have been coming into hospital. So this week we've had a better picture in terms of ambulance handover delays, because we're starting to get more beds being freed up, firstly by us discharging people who are recovering, but also the discharge processes are quicker now than they were a month or so ago. And we're working closely with our social care colleagues and with the community trust to make sure that we're supporting timely and safe discharge for patients that are ready to go home and no longer need to be in a hospital bed. And then the big concern for us, and we talked about this at the Trust Board last week, because it's a concern for all of us, is the impact on the number of operations, planned operations that we can do at the moment, because of the capacity constraints associated with COVID. And we've had to make some difficult decisions in order to postpone planned operations such as hip replacements and others. But we've also more recently had to start to postpone some cancer surgery as well. And I think that's a feature in a number of hospitals across the country. We've tried to mitigate the impact of that by increasing the number of operations that we can do on the Kidderminster Hospital site, which has remained, if you like, our clean hospital throughout the period. And as I think I probably described before, the Kidderminster site has taken on a lot more of the chemotherapy treatments that would ordinarily have been done at the Alex, in order to keep those patients that might be susceptible to infection as a consequence of their chemotherapy, that we can keep them away from the patients being admitted with COVID. But there's no doubt there has been an impact for us in our ability to treat cancer planned surgery in a timely way. We've been working with the independent sector, and colleagues will probably remember me, or certainly through our board, reporting in the first wave we did 600, 700 cancer patient operations through the private hospitals in the county under the national contract that was put in place with the private sector across the country. That's been more difficult in this second wave, because the national negotiations haven't enabled us to utilise the full capacity of our private hospitals in the county. And obviously the private hospitals have been wanting to do some of their normal private work, which perhaps is more financially lucrative for them. But as of recent times, last couple of weeks, we've secured more of the operating theatre time at particularly the Spire Hospital in Worcester, in order for us to start to do some more cancer surgery there, which I think is good news. But we remain concerned about the impact on those patients that are waiting for cancer surgery, and inevitably we will want to get back to restarting that as soon as we start to feel the demand coming through the door of COVID positive patients starting to reduce. It's difficult to say when or what that will look like, but it's top of our agenda in terms of making sure that we treat those patients and give them the best possible chance of survival whilst we're managing the COVID demand pressures. So Simon and Joe, I'll perhaps pause there. I know that you've got somebody else on the agenda coming to talk about vaccination, the vaccination programme. So I won't dwell on that, other than to say that we're still counting. It's a bit like the Georgia vote count. We can't declare until we've completed all the counting, but we think we've probably vaccinated about 5,100, 5,200 of our staff so far, which is pretty good progress. But we're still making sure that we've got accurate data on that. But I know you've got somebody else on the agenda talking about the vaccination program. So, Joe, I'll pause there, and very happy to take questions from colleagues about anything I've said or anything I haven't said that people are interested in.
Thank you very much, Matthew. And do any of the directors have any questions for Matthew?
No, not from me, Joe.
Martin, was that you? No. I was wondering.
I've got one, Joe.
Okay, thank you, Simon.
Yeah, I don't know whether I missed it because I had a courier trying to sort out his van on my drive, and the dog didn't appreciate it. I don't know whether, did you mention diagnostics, Matthew? And where cancer patients are with the 2-week wait?
Yeah, so no, I didn't. The 2-week wait performance for us has, apart from breast services, has continued at a reasonable level, not where we would want it to be in the normal situation, but we are trying as best we can to maintain diagnostic services. But of course, the difficulty for us is once the patients have had their diagnostic tests, rightly they're expecting to be added to a waiting list, and then we're coming in with difficulty in actually being able to schedule, particularly the cancer patients at the moment, as I said. So we're having to prioritize diagnostic testing for the emergency workload, but the 2-week wait for most cancer pathways other than breast is holding up at the moment.
Okay, and just one question was, in the first wave, we saw the numbers coming forward for the 2-week wait really dropping off.
Yes.
And then they started to recover.
Yeah.
Where are we now with referrals for 2-week wait diagnostic?
As I understand it, Simon, I'll check the data. I think those referrals haven't tailed off in the way that they did in the first wave, so which is a good thing. But obviously, it's a challenge to make sure that we're able to meet the 2-week timetable at the moment, time expectation at the moment.
Thank you.
Thank you, Jonathan. You've got your hand up.
Yes, I wasn't rehearsing to be the President of the United States. Matthew, you're under the cosh, and good luck, mate, and we admire your team. I just wanted to check on the stats, so I just captured what you said. I think you said 265 inpatients as at now.
Yeah, this morning, yeah.
About 43% of bed usage is COVID suspected or recovering. And then did you say 600 people died since the pandemic started? That's county figure, right?
Well, that's from the hospital, from hospital inpatients, those that have been admitted and subsequently died in our hospitals. Right. That's the number. It's not a county number. It's just those that come through our hospital.
Thank you. That's just making sure I recorded it correctly in my notebook. Thank you very much.
Yeah.
Yeah.
Thanks.
We have a question from the floor. Is somebody's asking what's the age and health profile this time compared with last spring?
Yeah, it's a good question. So we've seen in this second wave patients that are quite a bit younger. So rather than in the first wave, people in the sort of 65, 75 plus group, we're seeing more 40 and 50-year-olds this time round. Whilst a number of those are recovering quickly and discharging, we are seeing younger people dying this second wave. In terms of the health profile, it generally is the same as the time before, which is people with comorbidities, with other illnesses, and that picture is broadly the same for us as it is across the rest of England. We look at every single cause of death notification in detail. The chief medical officer in the trust reviews every single death and hasn't identified any, if you like, major issues or anomalies in terms of the care that and the outcomes that broadly are what you might expect with the difficulty of this with this disease. But yes, we're seeing a younger cohort of patients this second wave.
Thank you very much, Matthew. Is that a legacy hand, Jonathan? You've still got your hand up. I'll take it as a legacy.
Sorry,
Yeah.
I'll take it down. Yeah, there you go.
Okay. Has anybody got any other questions for Matthew? Because if not, I'll thank you very much, Matthew, for joining us, because we know you must be incredibly busy.
Pleasure.
And
pleasure. And Joe, if I can take the opportunity, never miss the opportunity to encourage everybody to whilst the vaccine rollout is going very well in the county, it isn't the panacea, and we still need to make sure we're complying with government guidance on social distancing, hand washing, and wearing a mask in public places. That's something that hopefully colleagues can continue to promote to everybody you come across in all settings, because I think there's still a number of months to go before we get the levels of vaccination across the county that start to give us a bit more comfort.
Yeah, brilliant. Thank you very much, Matthew.
Thanks, everybody. Keep safe. Nice to see you all. Bye-bye now.